Good afternoon. I'm Captain Pascal Lang, one of the 4th BSB PAs. We'll be doing a presentation on traumatic brain injury and mostly touching on severe traumatic brain injury. I would first like to start with 3 takeaways for this presentation. I'll be speaking mostly on severe and moderate TBI, but we'll be touching on mild TBI as well. Our job as first responders to casualties on the battlefield when dealing with TBI is to minimize secondary insults. We need to also consider other injuries from which the casualty themselves will most likely not be able to tell us about. And as always, treat pain. This is especially important in an unresponsive TBI patient who is in pain and having a physiologic reaction to that pain, which can actually worsen the TBI if not treated. But they are not showing any signs of being in pain. This is the agenda for the presentation. We'll be discussing the TBI definition and its or calculation of the average pressure of arteries during the cardiac cycle. And ICP is the measurement of the pressure exerted by the fluids within the brain, such as CSF. MAP can only directly measure through very basic methods, but we are able to estimate it with the above equation, which is the diastolic blood pressure plus the systolic blood pressure minus diastolic divided by 3. Since the MAP is an estimate and we are unable to directly measure the ICP without invasive measurement, the CPP, at least in pre-hospital setting, is not a real consideration. But we can tell by the equation for CPP that after a very large ICP, for which there are obvious physical exam findings or abnormal vitals, the MAP is a driving vital in the pre-hospital setting for TBI treatment goals. Generally speaking, systolic blood pressure of around 80 to 90 milligrams of mercury or permissive hypotension in the setting of TBI, where the casualty is assumed to have an increase in ICP, may not be enough to adequately perfuse the brain and it can cause ischemia. The BP goal in a TBI patient is systolic blood pressure greater than 90 or MAP greater than 80. A single episode of hypotension can have disastrous results for recovery, and permissive hypotension will worsen outcomes in a casualty with a brain injury. For primary brain injuries, or the initial injury, contusions are bruises to the brain, while hematoma are caused by bleeding within the brain, such as subdural or subarachnoid bleed, and diffuse axonal injuries are spread injuries to the axons. Direct cellular damage is a direct disruption of cell within the brain. Losing the blood-brain barrier allows substances found within the rest of the body to get into the brain, which causes damage to the brain. As a function of the barrier of the blood-brain barrier is to keep these substances out. It is important to note that there is no treatment for the primary injury. One important concept is the difference between concussion and contusion. A concussion is a momentary dysfunction of the ion channels within the brain. This resolves rather quickly with no lasting injury. The multiple concussions can cause lasting injury if the brain is not given time to rest and recover that it requires. Generally speaking, a concussion can be part of the mild TBI algorithm. Contusions is similar to a concussion or a contusion anywhere else in the body, except the brain is much more fragile and more susceptible due to the brain tissue and the non-expandable skull. A contusion can cause surface hemorrhage, causing a longer period of unresponsiveness, and can seem similar to shock. Hematomas are different types of brain leads, causing pressure within the skull, which will increase the ICP. With increasing ICP, the CPP will decrease. Blood is also irritating to brain cells, causing damage to those cells. Diffuse axonal injury is the physical shearing of axons, which you'll see as a direct response to an IED blast. The role of the blood-brain barrier is only to allow certain brain-friendly substances through into the brain so it may function appropriately. Disruption allows non-brain-friendly substances to get into the brain. This causes cell damage and irritation. Secondary brain injuries can be divided into 2 groups. The first is the neurotoxic cascade, which is a massive release of neurotransmitters and ionic shifts within the brain causing cell death. The neurotoxic cascade is a direct result of the primary injury, and and ongoing damage to the brain. And it causes ongoing damage to the brain. There isn't anything that can be done pre-hospital to prevent this cascade. Secondary insults should not be confused with neurotoxic cascade. These secondary insults are conditions or circumstances which can further accelerate brain damage, and these include hypoxemia, hypotension, hyperglycemia, seizures, and hypothermia. The cornerstone of pre-hospital TBI treatment is in preventing and treating these secondary insults to prevent further damage to the brain. It is important to note that a single episode of hypotension or hypoxemia increases mortality by 150%. Hypotension will cause ischemia, which intensifies the neurotoxic cascade. So the goal of the systolic blood pressure is greater than 90 or a MAP greater than 80. Hypoxemia will also cause ischemia as the cells lack oxygen, which also intensifies the neurotoxic cascade. The goal for oxygen saturation is to have it greater than 90%. Hyperglycemia is associated with worse injuries and should be normalized, meaning less than 100. But this is difficult in our setting as it takes insulin. But the glucose level should be checked so we can inform the incoming treating team. Hypothermia should be treated as this increases metabolism of the cells and worsens injuries. And then hypercarbia, or too much carbon dioxide, causes vasoconstriction, which decreases blood flow and decreases perfusion. Seizures, just like hypothermia, increase cell metabolism, which worsens injury and the neurotoxic cascade. Ultimately, these secondary injuries cause brain edema, which not only damages brain cells but increases ICP, which leads to further compression of the brain cells and increasing ischemia, worsening the neurotoxic cascade or leading to brain herniation, which will lead to death. During the physical exam, it is important to look for signs of skull fractures, which may be apparent, such as the battle sign, which is bruising around the mastoids, and raccoon eyes, which are bruising around the eyes. There may also be a cerebrospinal fluid leak through the nose or ears. During the physical exam, it is important to determine the pupillary response, as a fixed dilated pupil can indicate impending brain herniation and death. It is important to note either unilateral or bilateral fixed dilated pupils. This is an image of the battle sign, and this is associated with fractures of the lower area of the skull. Then these are raccoon eyes, and note the bruising around the superior part of both eyes, and this is associated with orbital fractures. And here's an image of a unilateral fixed dilated pupil. And in the setting of severe TBI is a sign of impending herniation. I'll touch on the MACE, which was developed to track mild TBI progression. This tool is not used to determine treatment or management of TBI and is not useful for moderate or severe TBI. It is important to perform the MACE within the first 4 hours of an injury, but it should be as soon as possible. A second MACE should be performed around the 48-hour mark. I don't think it will be useful to go over the actual MACE during this presentation, as it is better suited for in-person training. The goal in the pre-hospital setting is to treat or prevent any secondary insults, which worsens the neurotoxic cascade. It is also important to monitor for increased ICP with frequent neurochecks, examining the pupils, which may indicate impending herniation. Sedation and analgesia may also decrease baseline ICP and should be considered. A simple maneuver that one can do is elevate the head of the bed by 30 degrees. This will aid in decreasing intracranial pressure. As with all injuries, treat pain, and even unresponsive casualties can still feel pain. We'll now further discuss the secondary injuries in the setting of severe or moderate TBI, as this is the combat medic's treatment for TBI, and is ultimately what is expected that you know and are able to treat or manage. The two secondary insults that can easily be managed by medics are hypotension and hypoxemia. TCCC does address seizures, and acute seizures and seizures prophylaxis should be addressed. Hypothermia in the setting of severe TBI likely requires IV Tylenol, which we do not typically carry. And hyperglycemia requires insulin, which needs to be refrigerated and closely monitored, and is not a medication currently available for use, and can also be very dangerous when administered. For hypotension, the standard is to maintain systolic blood pressure greater than 90 or having a MAP greater than 80. No permissive hypotension. Again, I know TCCC talks about permissive hypotension. In the setting of a severe TBI, permissive hypotension will definitely worsen the TBI and possibly cause the patient to die. And then hypovolemic shock should be treated with fluids and blood products if indicated. For hypoxemia, we need to maintain the O2 saturation greater than 90%. Also, need to assist breathing with BVM if needed, and then take appropriate steps to manage the airway if indicated, such as a supraglottic airway. Generally speaking, if you're a severe TBI, your GCS is going to be less than 8, and the hospital answer is to intubate. This is a more difficult question pre-hospital, but don't be afraid to do an advanced airway such as a King LT or an iGel. For seizures, seizures should be treated prophylactically if the GCS is less than 10. All active seizures should be treated acutely. Active seizure medications are benzodiazepines such as lorazepam or diazepam. These are controlled substances, and you won't have too much experience with them in training, but downrange, you'll have some controlled substances. But they'll definitely be at the roll 1 or roll 2. And then what can also be found at the roll 1 or the roll 2 is phenytoin or Keppra. These are the typical prophylactic seizure medications. So impending herniation can be indicated by neuro exams and pupillary exams, which require emergent treatment to prevent death. These medications can be found at the roll 1 and roll 2, but not typically given to line medics. These include mannitol and hypertonic saline. The prognosis for these casualties are generally poor, especially if occurring in the roll 1 and roll 2. Additionally, the Cushing's reflex is a classic sign, meaning you probably won't see this in real life, but the Cushing reflex is when you have elevated blood pressure, bradycardia, and agonal respirations. This is a sign of impending herniation. I gotta kick my dog out the room. For mild TBI, there's a GCS of 14 to 15, can be diagnosed based off of the mechanism of action and symptoms. Any blow to the head can cause a mild TBI. This is the type of injury that the MACE was created. The pathophysiology of a mild TBI are ionic shifts causing momentary disruption of brain function. This is different than a contusion, which can be thought of as a bruising of the brain, which leads to swelling and potentially superficial bleeding of that brain tissue. Symptoms are usually mild, and we do expect symptoms in a mild TBI. You can have some episodes of vomiting, but persistent vomiting can be an indication of a brain bleed. In general, the symptoms of a mild TBI improve. If they are worsening, then they likely require further evaluation. Brain rest until resolution of symptoms is the cornerstone of mild TBI treatment. Like any other body part, once injured, there is a period of time where that brain needs rest. Brain rest includes not performing activities which take concentration, such as writing memos or playing video games or even reading. A single mild TBI can resolve within 48 hours, but subsequent mild TBIs can take longer to recover, especially if the occurrence is within 12 months. Return to activity or return to duty is based on symptoms, as there is no reliable test to evaluate a mild TBI. For special considerations, scalp lacerations should be managed. This is with either sutures or staples, as direct pressure may not be enough to stop the bleeding. It is possible to be in hemorrhagic shock due to a scalp laceration. This is due to the large amount of blood vessels in the scalp. C-spine precautions should be considered with all TBIs. And then leave any impaled objects. Secure them as best as possible without moving them. And casualties with penetrating injuries should also be given broad-spectrum antibiotics. In conclusion, TBI is a spectrum of injury from mild to severe. This presentation focused mostly on severe or moderate, but the vast majority of TBI during these almost 2 decades of conflict have been the mild TBI. The primary injury cannot be treated, and only time will unveil how much the brain heals. But we can prevent further damage by minimizing the neurotoxic cascade by managing secondary insults. The secondary insults we can realistically manage at the role 1 or 2 are hypotension, hypoxemia, and treating seizures. Remember to treat pain. Even in an unresponsive patient, they can still feel pain, but they are not able to make you aware of that fact. And then do not forget about associated injuries in TBI, which must be managed by you. C-spine, scalp lacerations, and penetrating injuries. Please let me know if you have any questions. Thank you very much.